am Dr. Laura Patel. I am the Chief Medical Officer at Transitions Life Care, which is a nonprofit, community-based hospice and palliative care organization in Raleigh, North Carolina. And I'm really privileged to be able to share our experiences with the Medicare Care Choices model, which is on the other side of the spectrum than we just heard. So it's a Medicare population. I don't have disclosures, but I do have some restrictions on specific data that I can share because this is an active pilot with CMS. And I just have to state that any opinions that I do share are really my own and may probably not impact anything CMS cares about, but I will share them anyways. So Diane covered a lot of this background when we first started. We know that hospice utilization is actually increasing and fewer people are dying in the hospital. But we still have very short length of stays, with almost half of people receiving care for less than 2 weeks. So why is this? We have a really great model for end-of-life care in hospice, but people are either never accessing this, or if they are, it's only in their final days. And we know that we could do better. We could give them more support if we had more time. So let's talk about some of these barriers. First and foremost, again, it's that need to forego curative or disease-directed treatment. That's a big barrier for people. And this is increasingly challenging as our medical culture and research is finding the latest and greatest, newest technologies, chemotherapy, surgeries, and our patients, it's very hard for them to decide, to choose to give up those options. Another issue is that patients and families, they don't want to have the feeling that they're giving up. And that's still the perception, as many have mentioned, that going to hospice means we're giving up on mom or dad or whoever. And I think that many people still have that perception that hospice really is only for those last few days. It's when really you're actively dying and it's time to call in the troops. And another issue is our healthcare culture. We still view dying as a failure. And I think it's really hard sometimes for our physicians and health professionals to feel comfortable talking about serious illness and goals of care. Prognostication is another challenge. I think this is becoming increasingly difficult as we are having, these new developments. We're having people who are dying from progressive chronic illness, which can have variable trajectories, as Dr. Twaddle mentioned. And so with development of immunotherapies, that has changed the landscape of cancer and even prognostication in that area. So this is challenging for physicians to say, yeah, I think that we only have 6 months or less. So that can be a barrier for hospice as well. So in 2014, CMS announced a new model called the Medicare Care Choices model. And this came out of the Affordable Care Act as well, from the Center for Medicare and Medicaid Innovation. And this was really intended to test an approach that would allow patients to receive so-called curative or disease-directed treatment while simultaneously receiving hospice-like support. So if we take the hospice out of the title, but we provide similar support without any restrictions on treatment, would more people choose to access this support? So CMS will be looking at, does this impact quality, satisfaction, and also what impact does it have on healthcare utilization and hospice? So initially, the original plan was to enroll 30 hospices over a 3-year period, but there was actually a lot of interest amongst hospices across the country, and so there's actually 140 hospices participating in 2 phases. With the first groups had started enrollment in January of 2016, which is the group that we are participating in, and then the second group will start next year, and this will go for a total of 5 years. So as with any Medicare pilot, there's a lot of eligibility criteria, and some of which have changed along the way. But first and foremost, this is a hospice-eligible population. So all of these patients must have a prognosis of 6 months or less, as determined by 2 physicians. They are looking at 4 diagnostic categories, so heart failure, chronic obstructive pulmonary disease, cancer, and HIV/AIDS. And again, this is a Medicare population or duly eligible. They can't be actively in a Medicare Advantage program or managed care, and they can't recently have received hospice. They have to live at home, and they have to have had some healthcare utilization in the prior 12 months. And this has recently been reduced to allow for a little bit more ease of enrollment. So now we need our patients to have at least one hospital encounter. And by encounter, that means an emergency room visit, an observation status admission, or an actual hospital admission. And they also need to have at least 3 office visits in the prior 12 months to qualify for this pilot. So this model is really based on the interdisciplinary framework of hospice and the conditions of participation of hospice. And the focus of the model is really on care coordination, shared decision-making, and symptom management, and truly that strength of the interdisciplinary approach. Patients, well, we actually like to call it hospice light or palliative care heavy because it does offer more than your traditional fee-for-service palliative care consultative approach, but it's less comprehensive than hospice. Patients do receive 24/7 access to nurses, which includes home visits in the middle of the night if needed. And we use our dedicated on-call hospice staff to manage this. We've developed some routine order sets for symptom management that primary care physicians can elect to sign when their patients enroll in this program. And that allows our nurses to have some ability to manage these patients at home. But what we find oftentimes is that when they're calling in, they're often managed by our triage nurses. They need reassurance. They don't necessarily need a visit. And if they do need a visit, it's usually because they're in a crisis. And a lot of times that's because they are now reaching out and needing hospice. So hospices receive a payment of $400 per beneficiary per month, or $200 if the patient is enrolled for less than 15 days, unless it's the last month of service on the program. So this is very different than the payment model for hospice, which is a daily rate, and it's meant to be comprehensive. It's based on 4 different levels of care, and it's meant to be all-encompassing, providing everything that patient may need that's related to their terminal prognosis. Things that are typically covered by hospice that are not part of this program and that are still covered under Medicare Part A, B, or D are things like therapies, medications, equipment, ambulances, and hospitalization. Those all go through their traditional Medicare. Patients are still subject to those 20% copays for all of those additional things as well. So we've been able to successfully integrate this model into our organization, in part because we already had a pretty strong infrastructure of providing non-hospice palliative care in the community through our nurse practitioners. And this program allowed us to kind of share staff and responsibilities and leverage them both to make both programs more successful. So our nurses on the Care Choices program also help triage our palliative care patients. The social workers serve dual roles, as does our medical director. And our chaplains we share with the hospice side. Our nurses on this program are not hospice nurses, but many of them were prior hospice nurses or prior hospice admission nurses, and that experience that they bring is really helpful to this program. They do, though, have a strong skill set in communication, which is really essential as they are really the touch point for patients and families. And also strong assessment skills because they are the ones who are in the homes and identifying problems and issues that they can then bring to the attention of the medical team. Other programs who are doing this model have successfully integrated it into their existing hospice teams. And this is ideal for a truly seamless continuity of care because it's literally the same team. I think some of the challenges with doing this approach, though, is that it can be hard sometimes for hospice nurses to live inside that gray area where goals of care are still being worked out, patients still accessing treatment. And so as an organization, we would need to then support our hospice nurses to make sure that they have the resources and the skill sets to be able to support the patients. So this team has a lot of collaborations in our community, and I'll just share a couple examples here. We have, one of our hospitals has a telephonic heart failure team, and they've really started referring a lot of patients to this program because they felt like we could be their eyes and ears in the home, and together we can work to help keep these patients at home and out of the hospital. We've also worked with a few pharmacies who provide enhanced medication counseling and home delivery of medications, which has been really helpful. The vast majority of our patients are also followed by our palliative care nurse practitioners. And this allows us to do a lot more active symptom management and assist with complex decision making. And I think this is a real strength of our program. The collaboration with home health is a little bit more of a gray area still. And I think that this model and the way that it's paid doesn't maybe necessarily accommodate for highly frequent skilled nursing needs. And so I think we need to continue to evaluate what the role is. We see the role of the nurse in this program as an advocate, the person who's identifying needs, communicating and collaborating care for that patient, but maybe not necessarily the person always providing that skilled hands-on care. The nurses in our program are really that thread that holds all of these pieces together and really are that person for the patient and families to come to. And they're able to build that trust and rapport fairly quickly with our patients. So there's no typical patient, right? But again, these are hospice eligible patients. But our patients who have cancer usually are receiving some active treatment, and that's usually the reason that they chose not to elect hospice at this time. So as you can imagine, the oncologists in our community really love this program. They refer to us a lot because they don't have to kind of make a choice right here and then. And this team can actually sort of help with that process of figuring out, is this treatment still helping? Is this still effective? And making it a little easier to make a transition. So these patients usually receive care for kind of a defined period of time until that decision has been made, and then they often transition to hospice. Our patients who have heart failure and COPD, as we know, can have a more variable trajectory. Many of them are elderly, have multi-comorbidities or multi-morbidity, as Dr. Twaddle says. And when they come to us, they're often coming out of a hospitalization or a rehab stay, and they can look pretty rough. They can even look like they're in their terminal decline. But after putting some supports in place, we know this with hospice, you take care of people and they do better for a long period of time sometimes. So they can have a variable course. We've not had much experience yet with the HIV/AIDS population. But the common denominator amongst all of these patients is that these are people who are hospice eligible, but they have chosen not to pursue that as an option for various reasons. So there's a high likelihood that this group may never have come to hospice. There's too many barriers for this group. And yet what we find is that the majority of patients who we care for on this program do die on hospice. And I think that speaks a lot to the impact of this high-touch, interdisciplinary approach and the ability to develop trust and rapport, and that allows for time for patients and families to figure out, what do I need? What do I want? So as with any program, especially a pilot, there's definitely areas that could be improved or grown. And I think first and foremost is that prognosis limitation. So I think that's a barrier. And we feel like by the time we get in there, sometimes it's late. We want to be in there sooner. We'd love to be able to offer this service for people who have a 12 or 18-month prognosis, or based on disease markers or functional need to determine which patients need us. Some of these patients have heavy care needs, and these are hospice-eligible patients. So they come to us with physical needs, emotional needs. They benefit tremendously from aid support, patients and caregivers, but doing that on a frequent basis with this payment model probably is not realistic or sustainable. And I do think that there does need to be more clarity on how this program fits with other home supports, such as home health, so that both programs can be maximized. We'd love to see it expand to other diagnostic groups. Dementia and ALS have long periods of caregiving needs, and I think this could be really beneficial. And end-stage renal disease, that's an area that traditionally underutilizes hospice, in part due to conflicting payment models, and I think could seriously benefit from a program like this. But I think there's also many strengths to this program, and first and foremost, it is reaching that population who may never have come to hospice, who had major barriers to hospice. And I think people don't want to feel like treatment options are being taken away from them. So this allows for a little bit slower discussion, time for decision making, and for patients to be able to take their time to make that decision. I wonder if this may help, this program might help traditionally underserved communities, racial and ethnic minorities who traditionally underutilize hospice. I wonder if we'll see an increased use of this program, and hopefully that might translate to actually increased hospice by decreasing some of those barriers. It certainly does provide some caregiving relief and the 24/7 access, which is critical. To have somebody pick up the phone in the middle of the night, and like I said, a lot of times it's just reassurance, but when it's time for hospice, when it's a crisis, we're able to make that transition very smoothly with very little delay or disruption to the patient or family. And I think that's why it's really important to have a model like this embedded into a hospice framework. And most importantly, it's really the ability of the staff to develop that trust and relationships that make this program successful. So I live in North Carolina, and I'm not a native Southerner. So when I got a porch and I got rocking chairs, I felt like I really arrived. And I spend a lot of nights out here, and I look to my neighbors, and most of my neighbors have a similar setup where they can just relax, put their feet up for a little bit. And I was at a local presentation recently, and I heard a presenter say something that really resonated with me, which is that programs like these are a way for people to come and sit on the porch for a little while, to take their time, get to know us, and then maybe eventually feel comfortable coming inside the house. So I think that, many people just need that little extra time, that little extra reassurance that bringing their loved one to hospice doesn't mean that they're giving up. And we see that a lot. Some of our patients, they just need this one conversation and then they go right to hospice. Other people need more time on the porch. And still others, they never ever want to use hospice, but they still are getting additional support through the end of their life. And so I think I'll just quickly illustrate this, no better than a patient story, the story of Brenda. So she was a 68-year-old woman who had end-stage COPD. And our Care Choices nurses have been following her for several months in the community. And they had had some impact on limiting her very frequent hospitalizations. But ultimately, before Christmas, she found herself in the hospital again. She was intubated and in the ICU. And her nurse came in, met with her and her family, and she knew from prior conversations that Brenda didn't want long-term ventilator support, and that looked like where she was heading. And fortunately, Brenda was still alert enough where she could participate in this discussion. And she was able to write down that she did not want to be on a ventilator. She wanted to be extubated. And so this nurse helped communicate to her family, to the care team, and then helped arrange for a hospice admission in the hospital where she was extubated, and she died peacefully with hospice support and her family by her side, who are now receiving bereavement support. So from a statistical standpoint, this might sound like a failure, right? She went to the hospital numerous times in her last 3 months of life. She died in the ICU. But that's why people are so much more than statistics. This is what was right for her. This was the path that she needed to go down. And Brenda and her family received so much more support than they would have otherwise if this program didn't exist. And even on that last day, they received guidance and reassurance from this team. So I think ultimately that's what this program is about. It's about meeting the patient where they're at, wherever that is, providing whatever support we can for whatever time we can for these patients and families who have a great need. Thank you.